blade routine, some tubing exercises, and then a rebounder routine. And they'll do those set exercises, and I really use it as a time to kind of get an idea of how the guys felt, what they did, how far they threw, if they long tossed, how many pitches they threw in the bullpen, and really use that as a time to communicate with the guys and see, how they felt when they did whatever activity they did, and then how they perceived how their body felt. And then from there, I'll dictate some of the sets and reps on those different exercises. And then from there, individually, we come up with a routine, whether it be massage, using the Normatec, using the BFR, floss bands, getting on the arm bike, dry needling, cupping, Hivamet, complex E-stem, and kind of figure out what guys respond to best. And then, obviously they'll continue with that program into the spring. And, if things arise and we need to change things up, we at least kind of have tried everything in the fall to figure out what our go-to is and what works best for each individual. So that's kind of, a brief synopsis of our arm care routine. Obviously, I think Jason and I talked about we want to open it up for questions, but then more so really just have a discussion after that as well.
Josh, what are some ways that you're kind of figuring out different set and rep schemes for guys, and maybe even some justification on particular exercises? Are you just searching for them to enjoy it and feel good, or I know you said you base it kind of off your screen. Can you talk a little bit about that?
So with the screening, obviously I look for any kind of deficits, whether it be T-spine mobility, hip internal external rotation, all that, I use that to kind of dictate my pre-throwing PRI routine. With the sets and reps, post-throwing, I really try to talk to the guys about, well, how'd you feel, and what their perception of how their body felt, which is kind of big. I know we're trying to preach on recovery, whether it's nutrition, sleep, all those different habits, but finding out how a guy perceived his arm or his body, whether it's be a flush throw after either a bullpen or an outing, or just a long toss day, and kind of seeing how they word their description of how their arm or body felt is kind of how I can dictate the sets and reps on everything. If a guy's like, wow, my arm felt like poo, I can't really seem to get over whatever, or I felt great. We may, if your arm felt great, we may do a little bit more sets and reps, depending on where we're at in the fall. And then, if a guy's sore, we may tone it down with the normal routine and then kind of focus on some additional care.
Hey, Josh, this is Brandon Platt from Miami. I was just curious with your recovery routine. Are you guys doing all of those things every day? So cuff program, body weight program, tubing program every day. Are you splitting those up into days based on what their throwing was for the day and where they are in the season? For example, what is your thought process with a long toss day? Are you going to do more or less cuff work post just because the shoulder's already fatigued and that kind of stuff? Can you talk on that a little bit?
Definitely, yeah. Good point. So basically, with the body blade routine, They don't do all that in one day. No. I use the body blade as a recovery day, like when they do a flush throw from a bullpen or a live outing. So that next day after they flush throw, that's when they'll use the body blade. Um, Days that guys will long toss, they'll typically do a cuff weight routine with 2 or 3 pound dumbbells. You're exactly right. Depending on how guys felt and how far they went, depends on how many throws they had to make. We may tone that down before a bullpen. So the day before a bullpen, post throwing will typically be a tubing routine, and then with bullpen days, I use the rebounder as a post throwing exercise. And then anytime guys throw live off the mound, whether it's in a scrimmage or a game or whatever the case may be, I use a set of manual exercises with the eccentric concentric contraction, and then guys any day that they get off the mound, whether it's a bullpen or a live outing, after they do the manual exercises, they'll do or rebounder, they'll do a mobility routine, going through just some T-spine rotation, and some different stuff with that. So good question, and I apologize I didn't bring that up. That all that's kind of broken down in terms of what they did that day.
Awesome, thank you.
Josh, Chris Wheeldriver from DBU. Do all of your guys do the same stuff pre-throw, or do you have guys that do different things? Is it individualized? Can you talk on that?
Sure. The PRI breathing routine is individualized based on the assessment that I use. So for that's definitely individualized. Now there may be a handful of guys that kind of show the same postural alignment, and so they're doing the same routine, but those are individualized. Now the soft tissue work, I kind of let guys dictate that on their own, in terms of what they focus on, what they use. A lot of our guys like the Hyperice, Hypervolt, and then they'll use the Hypersphere as well, just to kind of roll out. If a guy is slacking off and not spending as much time as I feel like they should be on there, then we'll kind of look at things in terms of additional things that they can spend time on. But that I try to let guys dictate on their own. The mobility and movement routine is something that our guys do, and our strength and conditioning coach and myself basically came up with that. And we have probably, I think, 4 or 5 different routines. And what we try to do is break it up. And so it's not so monotonous. Every couple of weeks we'll change it and kind of rotate that through.
What about with the weighted ball stuff and crossover? Do they do the same things, or do you have different?
Well, this year we actually had Driveline come in and do an assessment in the fall with all of our guys. And so we don't do any of the actual throws with the Driveline stuff. Our guys typically, all they do is the plyo care. And that may differ depending on, the day, what a guy's doing that day in terms of, whether it's a bullpen or a long toss day, as well as like any of the deficits that we picked up on. One guy may do reverse throws and that's it. One guy may do reverse throws, pivot picks, and walking windups. Just depends on what mechanically we're trying to fix with that individual, or trying to incorporate.
Josh, this is Ken Wainwright at the University of Kansas. Two-part question. You mentioned your strength conditioning staff. How involved are they with you in this weekly routine? And then can you speak to how your routine changes when you're on the road?
Definitely. So our strength and conditioning staff, like, we go hand in hand. They are, we talk about, what our guys are doing arm care wise, and then, he dictates there from, what they do lift, which is really helpful. We've started to incorporate a med ball throwing routine in the weight room with our pitchers, as well as like some other mobility and movement stuff with those guys based on my assessments. And I love our strength and conditioning coach. He tells me all the time that he's not doing his job if guys are in here more than they need to be. And so we go hand in hand developing everything. And then in terms of when we get on the road, it changes a little bit. I mean, I'm able to bring, quite a bit of equipment. And we have all of our guys they use, or they all have lacrosse balls. So, in terms of the Hyperice stuff, they can still get like the lacrosse ball, soft tissue stuff, in the hotel room. And typically what we'll do is they'll go through in their own room some of the breathing exercises, and then soft tissue work before we get to the field. And so that way they've already got some of that stuff done. And then from when we get to the field, that's when they shift their focus on the mobility and movement routine.
Hey, Josh, how does your routine change for relievers versus starters? Guys that are going to throw, instead of every fifth day, every seventh day, they're throwing every other day or 3 days in a row.
So more so for the relievers, that's where we really get the additional arm care. Over the past probably two years, we've had more guys start using like the BFR. And one of the things that we've started doing is both with using activity with the BFR, but even sometimes just with a stagnant, they'll hop on the table and lay and use the BFR for an 8-minute routine with no exercise. And a lot of that depends on if the guy was a middle relief guy and he threw a ton, or was he the closer where he came in and just threw one inning. And so to be honest with you, with our relief pitchers, the BFR and the cupping have been the two go-to exercises, additional stuff that they utilize.
Hi, I'm Annie. So do you do any other screening besides PRI at the beginning? Like, do you do any total arc or anything in regards to that at the beginning of the season?
So with screening, I do the screening 4 times throughout the year. Pre-fall, when guys first get on campus, and then post-fall, pre-spring, post-spring. And to be honest with you, it's not just a PRI assessment that I do. It does incorporate some of the PRI activity, but I'll look at ankle range of motion, dorsiflexion, plantar flexion, and go through the entire body. So it is a true movement screening that I use, but it also incorporates some of the PRI philosophy.
Josh, this is Callie Hannon from Toledo. I'm just wondering, for some of those schools that don't have all of the resources and all those different tools, what's kind of like your, if you had to pick, if you're in a pinch, your boiled down ultimate, what are you going with?
My hands, and utilizing either, active release, strain, counter strain, massage, working with guys. I feel like, regardless of what you use arm care wise, I feel like anytime you can, put your hands on individuals, one, they get a better response just because, that physical interaction for whatever reason, they feel like you're invested, they're getting benefits out of it. But then two, it gives me that response of, I can feel the soft tissue break up. I can, feel the tension and the length of the musculature that I'm working on improve. And so, to be honest with you, if I had one go-to, it would without a doubt be, my hands and doing some kind of manual therapy with, whatever that case may be.
Josh, obviously we got a lot of people from a bunch of different levels here. Would you be willing to talk a little bit about the differences between your situation and the staff at Ole Miss and kind of what you had to deal with at App State and how those two differed?
Sure. So, obviously, working it out when I first started, I didn't have access to some of the stuff, and to be honest with you, even with the change in states, I know, some states allow, athletic trainers to perform dry needling, and some don't. But that's where, one, I really got the ground, moving with manual therapy and active release, strain, counter strain, massage techniques. And so, the one thing, although I do have, a lot more access to different equipment and budgeting and stuff like that here, I haven't gone away from what worked. With using things like, floss bands and suction cups and things such as that. And so, that's where, when I, first started out, really tried to incorporate what I wanted to accomplish with arm care, with scapular movement, trying to protect the joints, and I have to give a lot of credit to Jason Roby. He's one of the guys that initiated me into the postural restoration world with everything, which I know that's a whole different topic and a can of worms. But that's one thing that has really been beneficial to me is getting into that world, understanding their philosophy on body movement, and evaluation and injury prevention. I think that's allowed me to get the shoulder blade and the rib cage in the proper position to, essentially prevent injuries. And when I have guys come in, the new guys in the summer, I'll take them through and just show them some of the different exercises and show them the improvement in range of motion that they get without stretching, and physically being able to take them through that, show them everything, and understand and kind of teach them, this is why we do this. I joke with them. I'm like, look, if you're not breathing, you're not living. And so, you got to breathe to live, but you've also got to breathe to, shut down different, areas of the body and stimulate certain areas of the body. And so, being able to take them through what that does physically kind of helps implement that for future. Them being able to see, I don't have to do the sleeper stretch to gain internal rotation. I can just do this one breathing exercise. It really helps with compliance with different stuff moving down the road.
Hey, Brandy from Georgia Southern. I have a question about buy-in with the breathing techniques. So with our pitchers, we've tried and we've actually added like mental management and sports psychology to try to work on their breathing, but just trying to get them to buy into it has been such a big, hard thing to get them to do. So when you do have those athletes who kind of don't buy in, like how do you approach them and like what tips do you have in terms of trying to get that buy-in a little better?
Gotcha. Well, to be honest with you, what I've always had a coaching staff that they've bought into the PRI world. You know, Chris Pollard, who's now at Duke, was a firm believer with everything. And so, to be honest with you, having the backing of the coaching staff for me personally has really helped. You know, our pitching coach here as well. He talks to guys, and fortunately for me, his wife is a PT, and so you know, it kind of helps again with everybody. So those guys that don't, you know, get a little bit of a pushback and don't buy in as much, one, having the backing and the coaching staff has really helped me. But then two, you know, I take an individual that has had issues, that, you know, either had an injury or you know, or whatever the case may be, where we saw improvements with his activity and injury because of the PRI stuff that we've done. Granted, I don't do just PRI. Like I use that, it's just a tool in my toolbox. But what I really try to do is for those individuals that don't really buy in and get some pushback, I have one of the older guys that had an issue, had an injury, and you know, saw the benefits from the PRI exercises. I'll go to them individually. Hey, can you help me out with this guy? Help me talk to him. Help me, you know, get into his head. Help me help him understand what this is doing. And so, you know, not only having the backing of the coaching staff, but, you know, getting individuals on the team to help communicate with everything has kind of helped with that buy-in.
Hey, Stan, I know this is Josh's subject, but it's kind of open to everybody. And I figure with your wealth of knowledge being in the room, it might be kind of useful for you to shed some light on maybe the different levels of baseball and things that you can teach this large crowd of baseball ATs.
Hey, Josh, this is Obi from Lamar University in Beaumont. And I guess just because we're kind of hoping to share, you know, this with other people, you know, is there anything that you would offer as far as just, you know, implementing arm care programs for maybe, you know, younger athletic trainers that are, you know, maybe an intern or someone going to a GA ship, just kind of any sort of advice for them going into baseball?
You know, the biggest thing, one would be developing a routine that you feel confident and comfortable with. You know, because the one thing that I know athletes will pick up on is if you don't feel comfortable and confident and back your own routine, then, you know, they're going to pick up on that. And so, one, you know, developing that routine that you feel comfortable with, but then, two, again, one of the things I touched on earlier is cueing the athletes for what you're trying to accomplish with the exercise. You know, developing the different verbiage that you want to use, just because, being in bullpens and different situations as well, one guy may pick up, and interpret a term differently than, the other 10 guys. And so developing that different cueing and verbiage as well, for the stuff that you want to accomplish, just because, if you're trying to explain to a guy to, again, retractor scaps or something, that cueing terminology may not work for everybody. And some individuals, you may want to, work on scapular control in a certain pattern, and other guys in a different pattern. And so working on the verbiage too, I think that's going to be, it would be another important factor.
Awesome. Thank you.
So now that Stan's mic is working, I'll ask again, Stan, if you don't mind throwing out some of your wisdom from baseball and your years of experience, we would appreciate it. Maybe not. Just to add to a little bit of the conversations that we were just having there in regards to buy-in and breathing and just getting guys to do particular things or implementing arm care stuff, I definitely agree with Josh. But I think some of the things you got to make sure that you do is, once you develop that relationship with that athlete and figure out what their goals are, kind of make sure that you draw back on those and not necessarily shove them in their own face, but maybe guide them in that direction and reminding them, and hey, if this is really where you want to go, then these are some of the things that you probably need to do to get there. And if you don't agree with that, you got to try it before you can deny it, type deal.
I think too, like going off of the question about new ATs in baseball, I think it's really important to kind of teach them the importance of individualizing, and there's no cookie cutter approach to what we do. So I feel like a lot of brand new GAs or interns who get into baseball, they just get so tunnel vision of every pitcher needs to look like this and that. And I think it's just really important just to add to that discussion a little bit about there's not a cookie cutter approach. Every single one of them is individualized, and they want to be treated like individuals too. So keeping up on that, I think, is really important.
Josh Ogden with just a brief comment on the buy-in. A big thing that helps with that is if you show pre and post. So if you're looking at total arc of the shoulder and showing the total arc of the shoulder, do your breathing exercises and then show them afterwards. And there's a bit of a salesmanship aspect to that, but that helps a ton with buy-in for me.
So I'm actually currently a graduate assistant right now. I'm finishing up my master's in athletic training. And I was wondering if you guys could give me kind of any advice. I've taken a couple like CEUs, and especially now that I have a lot of downtime, I'm really interested in getting into baseball. I know that the PRIs are very important, as you guys have been talking about. I've also taken a couple rock blades classes, but is there any other things you guys think that I should have under my belt prior to maybe potentially starting with a larger university in baseball?
I think diversity in your manual therapy and manual approaches help. Like I do manual muscle, like active release techniques. I also do cupping, dry needling, and I use floss. And so I think trying to get as many tools in your toolbox as you can. And I think like they were talking about earlier, your hands are really an important thing. And if you have one thing, it's your hands. And I 100% agree with that because I use my hands every single day. So I think the more you can diversify like your manual therapy part of your toolbox, I think that sets you up for a good spot with baseball.
I did actually do the sturdy shoulder solutions, and that really kind of blew my mind. Whoever put that in the group chat, thank you.
Well, if that's all we have on arm care, unless anybody has any last minute comments on that. All right, so now we're going to pass it over and talk about screening and prevention. Our speaker for this is going to be Josh Ogden. Josh is currently at the University of Baylor and has been there for the last 9 years.
Hey, can you guys see the PowerPoint that I'm trying to share right now?
Yep.
Was that a yep?
Yes, we can see it.
Okay. So we're going to go just real quickly through some of the screening stuff that I do with my guys. So basically, I'm going to touch a little bit on, so obviously we get, pitchers and position players both come in. They all do their PPE. They all do their movement screening, which is what I'm going to focus on today. Some will do a fusionetics screening depending on, based upon the movement screen I'm going to talk about. Depending on if we feel like there's more of a movement-based assessment needed, because the movement screen that I'm going to talk about, and honestly, if you looked at Josh Porter's screen, they'd probably be very similar because I might have stolen some of this from him. We'll do the fusionetics more movement-based. Then looking more at position players, we got a K-Vest right before the shutdown happened, so I was really enjoying playing with that, and would love to talk more about screening if I'd actually done it. TPI, we've got some strength staff that do that. On the pitching side, we'll screen more with high-speed video, edgertronics, 3D motion capture kind of thing. But on the movement screen, so a couple of quick thoughts on that. When I go through this, it's very PRI based because Josh Porter and I have similar backgrounds in that. So not to turn this into a posture restoration podcast or discussion, might not have been the best thing to have both of us present on the same day, but we do have similar thought processes, I think. So this is not meant to be an orthopedic screening. So it's not meant to be, you show up in an orthopedist's office and you go through a screen. We're looking for labral pathology, cuff pathology, anything like that. What I'm looking for is differences side to side. So I'm looking for asymmetrical side to side differences. I'm not looking for any absolute numbers. I think we've all had the pitcher that has 0 degrees of external rotation that throws 95, and we've all had the pitcher that has 140 that throws 85. So I'm not looking for absolute numbers. If there's any kind of a red flag, shoulder range of motion, hip range of motion, anything that indicates, shoulder pathology, they come back later for a full eval. What I'm looking for in movement screen is differences in asymmetries. So the goal is quick, basic screening, no more than 10 minutes per player. Now, being baseball, people wind up talking. That 10 minutes turns into 20, turns into 25. Ideally, I want to screen them, talk about the results, get the next guy in 10 to 15 minutes. Usually, I'm trying to run through 15 to 20 guys per day and do these screenings over 2 to 3 days in a given week. Other thing I look for is to do it cold. So I want the same numbers as if they were injured and we show up in a doctor's office. And the reason for that is if I measure a kid that we have 140 degree total arc, and then all of a sudden we show up in the doctor's office and they have 0 IR. Was that because they were warm or because, they now have some kind of labral pathology? And Josh mentioned that he does his 4 times a year. I do mine 3. Personal preference, availability of resources, whatever's available. I like to do it when they get back in, freshman JUCO kids when they show up in the summer, returners when they come back from summer ball, pitchers and catchers at the end of the fall, and then it's spring break. A lot of that is just availability of resources and time. And believe me, ideally, I would love to go through and do every player every other week. So what I'm looking at on the movement screen, and for those of y'all that have been to a PRI kind of course, if it looks similar, it's because it's based on kind of that screening. The first thing I look at is grip strength. So a couple of years ago, I started screening pretty much really all upper quarter evaluations, including a thoracic outlet component. So grip strength is going to be more of a reflection of thoracic outlet. And so what I'm looking for is I've got one pitcher that can max out the grip dyno at 220. I honestly don't know what his max grip strength is because my grip dyno doesn't go that high. And I've got others that go to like 80. What I'm looking for on this is typically, is their dominant arm stronger than their non-dominant? Now, what I have noticed on that line is in terms of catchers, their non-dominant arm, their glove side, should be stronger than their throwing side. The ones that aren't tend to not be very good receivers. So that's something to flag and work on for your catchers. Moving down from that, I picked Allen's and Ruse. So the first 3 on the screening form are all looking for thoracic outlet. I've got this on my next slide, but roughly 20 to 30% of my incoming kids I flagged for some kind of neurological deficit upper quarter. My lowest has been 10% this past season. My highest was 50% of my incoming class 2 years ago that we flagged on some form of deficit on these 3 tests. Down from that, elbow and wrist range of motion. In an ideal world, go through and use a goniometer. Like I said, I'm trying to go through these in 10 minutes. So usually it's arm straight, arm flex. If it looks normal, we call it normal. If there's some kind of deficit, typically an extension, then we'll circle back and actually measure that. Scat motion, I know there's some debate on whether static, dynamic, scapular assessment is of any value. I like to do it. So palpate medial borders, flex to the front, abduct to the side. Is it normal? Is it not? Typically what I'm seeing on this stuff is snapping scap, lack of control in the eccentric, something like that. That's something I'll flag and typically come back and look for underlying pathology later. Cervical rotation, do this supine hook line, goniometer at the top of the head, turn. Moving down to internal rotation, I measure both passive and active, but I only do this on the dominant side. So reason for this and getting into some of the functional range conditioning kind of stuff with joint controlled and controlled articular rotation, ideally I want to see, at least on the throwing side, the ability to actively internally and externally rotate the shoulder capsule or the shoulder joint within 4 to 5 degrees of the passive, because anything glaring deficiency in that, especially active external rotation, is going to transfer stress to the anterior capsule, potentially stretch that out, fray the posterior labrum. So if we think of the rotator cuff as a stabilizer cuff, I want to see how well it can stabilize the ball within the socket and rotate, especially into external. Shoulder flexion, horizontal abduction. Now the humeral retroversion, I've also got on my next slide as a question mark. So we all know that that can only truly be measured with ultrasound or CT scan. This test is basically, lay the arm across in adduction. Something Mike Reinold, I believe, posted a couple of years ago. It was kind of a quick, dirty, clinical, give you some idea of what you're looking at. Numbers on that one, you get really weird, like 25, 30-degree rotations. We don't have that in the shoulder. So again, what I'm looking for, if this number lays back to 30 and this one lays back to 10, I might want to go have that kid measured and actually look for what's their actual retroversion, retrotorsion numbers. Supine rotation, that's exactly what it sounds like. Supine hook line, how far do their knees rotate? And seated rotation, they're on a stool. So the grip strength thing, in an ideal world, I'd want to do a 3-test average for each of those positions. But again, I'm trying to go through these guys in 10 minutes. So if there's something that we flag, there's a 15-pound difference, non-dominant side over dominant, we'll circle back around and do that average test to see if it's something that is actually relevant. So I mentioned on the TOS thing, I see quite a few with some kind of a neurological deficit. Pick a couple of TOS tests. I don't care which. Alan Adson's Ruse military brace. Put your arm back in your max layback position, turn your head, and let me check your pulse. I've just found it's beneficial to check that and address it early. Elbow and wrist, again, ideally I'd measure it, but I don't really have time. Passive and active, talked about that one, talked about retroversion. Moving down to the lower body, active and passive straight leg raise, because again, if we have more active or passive range of motion, that can change firing patterns, that can predispose to hamstring injuries. So if we have an extreme active ability to flex the hamstrings to 140, but passively we can only get to 90, I have to find a way to match that up, whether it's eccentrics or some kind of active work. Again, from the PRI perspective, adduction drop and extension drop, that's Ober and Thomas. I look at that as a reflection of pelvis position. Abduction raise, how far does the leg go out? And then internal, external, and ankle dorsiflexion, plantar flexion. I put a goniometer down here because, ideally, that'd be what you would use. Typically, I'm doing these measurements by myself. At most, I've got a student that's working as a scribe for me. I use the little angle finder from Harbor Freight on the right. So what I'm going for, again, is not clinical accuracy as much as it is clinical comparison of side to side. So if I use the same tool, I line it up on the same aspect of the medial tibial crest, and I do it the same way every time I test these guys, I've got consistency, whether I necessarily have accuracy. So I'm looking at, what's the difference left to right, not so much what's the clinical accuracy, because I'm not doing this for a research study. I'm not doing this to be part of any kind of publication. I'm doing this to look for deficiencies. So I use the cheap tool. It gives me a reflection side to side. Is there a 10-degree difference? Is there not? That's kind of what I'm going off of. And then if I flag something with the cheap tool, I can always come back and do it, with more advanced later. And since I mentioned the other stuff, if we need more of an active movement screen, we use Fusionetics. It's basically FMS on an app. So it's the same test as FMS minus, I believe, the Y balance. And then if you do the test, it spits out a program. We typically vary off of that. KVest, we're going to figure that part out. We recently got that tool. I'm one of 3 on our staff that did the K-Motion certification. So ideally, we can look at, for our hitters, any kind of firing pattern deficiencies, things that we can address hopefully in the weight room. And then the high-speed video nitrotronic, that goes back to our pitching coach, and we don't use that until the fall when he's actually able to work. So that was the 7 slides I put together.
Hey, Josh, I got a question.
Sure.
You had mentioned earlier about how you been screening your guys and having them do the thoracic outlet test. So is that something you had just seen in the past and put that in there, or were you seeing quite a few guys coming through that eventually either end up having some sort of shoulder issue or actually thoracic outlet? Is that why you incorporated it, or is it just something that you like to look at?
So combination. Several years ago, so obviously we have our team physicians here in Waco, right? The doctors we use for second opinions up in Metroplex, they got to where everyone I sent for a second opinion, they were doing a thoracic outlet screening regardless of whether they had thoracic outlet symptoms. And it got to where probably 50% of the people I referred for a second opinion were being diagnosed with it's thoracic outlet and bicep tendonitis, or thoracic outlet and across the UCL. And it was something that just seeing them test so frequently for it, I just decided to start incorporating in every one of my upper core evaluations. And once I started incorporating that, I started flagging a pulse loss on ballpark 30 to 40% of all chronic upper quarters. And since I saw it so frequently in people that were already hurt, I just decided to start looking for it before people got hurt, if that makes sense.
Yeah, it does. I guess just that kind of goes into my next question, is that once you find these guys, what's your approach for them, on post mound, rotator cuff, or do you have them work on something specific every other day, or is it you just kind of just be mindful of it and keep an eye on them?
So typically I start working on the first rib mobility. And so one thing I've noticed on that, typical thoracic outlet presentation, you're going to see the drop shoulder, head shifted away. And so kind of what we're always taught on that is, well, stretch the scalenes. Well, if they're already in this position, the scalenes are already, stretched, even if they're hypertonic, so they're elevated to the first rib. So I actually work on relaxation of the scalenes and being able to draw the shoulder back and up, so inhibition of the pec minor and activation of the lower trap. And I actually work on relaxing the scalenes so then I can do manual therapy work to get the first rib to actually descend a little bit.
Okay, so it's kind of like a stress strengthening principle of anterior and posterior.
Yeah, exactly.
Okay.
Yeah, I mean, personally, I use some of the PRI techniques, but I've also found it doesn't really matter as long as you inhibit a pec minor and activate a low trap and relax some scalenes. What I have found is that if you sit there and just crank away on the scalenes, I don't see improvement in that.
Okay.
Josh, what number are you looking for bilaterally on range of motion stuff? Is it 10? Is it 7 degrees? Is it in your total arcs?
Total arc 10 to 15 typically. And a lot of that, to be honest, is just kind of a feel thing. Because if a kid's one of those that's really, really tight and they've got 90 degrees of total arc, if they've got a 10-degree deficit, that's different than a kid that's got 150-degree total arc that has a 10-degree deficit. At least in my opinion. And all of this is my opinion. I'm not at all trying to claim that I'm right on any of it.
What you mean? Is your word's not the golden word around here?
No. In fact, I'm kind of hoping some of y'all pick my thing apart so I can make it better.
How often do you show this to your strength coach?
Every time I do it. In fact, yesterday, so we do it 3 times a year, and I show it to our strength coach every time we do it. In fact, yesterday in a meeting, one of our administrators asked me, so how often do you and your strength coach meet and talk about what we're doing for these guys? Well, before this whole shutdown, about 2 hours a day in the dugout, formal meetings at least every other week, we sit down and talk about how we're going to integrate correctives. So we can ideally do a lot of these correctives as part of the lift, not necessarily a standalone rehab. Manual therapy, obviously, that's going to be more rehab based, kind of in the athletic training room. But as much as we can do as part of the lift, we try to do it. So kind of going back to what Josh Porter said, my strength coach is my best friend. And I tell him all the time that we're doing the exact same job, just different color weights. So if I'm doing my job, I get them back to him. If he's doing his job, ideally they never come to me.
How often are you doing this? Like when Graham was here, he didn't let us do any of that. And then finally his last year, he let us. We convinced him to let us do it. So we started doing it like at the beginning of the fall, and then end of the fall ball, and then in January, and then tried to get some of the guys done at the end of the season, but it was kind of hard because most of those guys pack up and head out for fall ball or for summer ball. So are you just doing this when they get back in August, or what are you doing?
So August for everybody. November, December, whenever we finish fall ball for pitchers and catchers, and then spring break for pitchers and catchers. And then also anybody that's been injured, we do at least once post-injury. Anybody I flagged as high risk, we'll do an extra time. So like if I flag somebody, in August let's say it's a shortstop that we flag for thoracic outlet, and we do the corrective work, they go through fall ball, no problem. And I'm using this as an example of one that actually happened. We'll go ahead and rescreen them both of those additional times, but not necessarily if it's a first baseman that had no red flags on their initial swing. And in an ideal world, I would do everybody way more than I do. I don't have the time of day typically with 35 to 40 guys and fall structure the way it is. Plus, in my current role, I oversee 4 other sports. So I'm spending, a third of my time in meetings and conversations with those other 4.
In the time that you've had this specific kind of protocol or program in, can you talk a little bit maybe about like I guess a decrease in the injuries that that you typically see with baseball?
Yes and no. So we've had issues over the years where, like last year we got hit by the injury bug really hard. But what I have noticed is a decrease, and I don't want to speculate a percentage. I've noticed a apparent decrease in chronic overuse injuries, specifically to like UCLs and elbow stuff. What I've seen more of in the last 2 years has been acute. So yeah, it sucks for a guy to blow a knee out or hurt a shoulder. But it's one thing if they do it throwing 100 pitches versus if they do it diving back into first and sublux the shoulder. You know, so overall injury numbers haven't really changed. What I've seen is less acute and probably more chronic, which I don't know if that's a function of luck or what that would be. But
Obi, I'll say, so I do something similar to Josh's, but it's a little more or a little less PRI based, a little more range of motion SFMA based. And I'll say that I don't think there's any way to get a number there in regards to actual injury reduction. I don't even really stress the fact that what I do is for injury reduction. I stress that it's more movement capability and qualities. But there are some other ways to skin that cat. And I will say that just doing what I've been doing, each institution that I've been at, the numbers have went down from year to year, but I would not be willing to say that it's directly correlated to doing this and correctives because of it.
I'd agree with you on that, Jason. We've been doing it for probably 10 years, and we've modified it a few times. We use a version of an ortho and TPI mix, and I think you just catch stuff a little bit earlier. You can find out guys that have limitations and attack those before something bad happens, but I don't think you can put a number on it.
yeah, and I agree with that. I think you catch the little stuff before it becomes big stuff, but you're still going to have injuries. It's part of the game. I mean, and if you look at this form from my initial version in 2014 versus now, it's similar enough you would recognize it, but not much. So it's definitely changed over the years, and I don't have enough consistency of data to say, okay, this is my 6-year window of here's what we've done. It's definitely been a growing document over the years.
Are you having like anybody else input this or have any input in this? Like for us over here, what we do is I use my strength coach quite a bit on this stuff because he takes a lot of the screening stuff and puts it into the weight room, which I guess for me makes my job a little bit more easier because then I don't have to worry about a lot of this stuff. But we've also got the PTs from the hospital that come over and put some stuff in with it. So did you do that, or did you kind of just go off this like what you said back in 14 and then kind of add and subtract some of the stuff over the years?
Pretty much just all on my own. Add and subtract over the years. I mean, I've taken input from PTs, orthos, strength coaches. We've tried tests over the years to see if they correlate with injuries, movement quality issues. Either leave them, don't leave them. It's just kind of there's the core stuff of the grip strength, internal, external, shoulder flexion, front rotation, hamstrings, Ober's, Thomas, and hip internal, external. Other stuff I've played with, like there was one year I measured big toe dorsiflexion. And then I got to thinking, our guys play in 7 or 9 points of contact on hard plastic soles. that don't really dorsiflex. So how much does hallux dorsiflexion really matter for our guys versus like a soccer player?
Yeah, I've seen dorsiflexion starting to pick up, which kind of struck me as odd, but it was mostly in basketball. I'm just like, all right, well, I mean, I guess it doesn't really translate over to baseball, but you know.
Yeah, like basketball, soccer, volleyball, maybe basketball and volleyball more than any. Like hallux dorsiflexion, I think would matter, but with the types of shoes that our guys play in, like how much, if they have 40 degrees of or 30 degrees of big toe dorsiflexion, but their shoe only lets them get to 8, how much can I reduce injury risk, to shoulder or elbow by working on big toe flexibility?
I might have missed. Do you look anything at all in guys being upper trap dominant and not having any lat activation whatsoever? Because I see quite a bit of that with my guys, that they can't activate their lat at all, but they're very upper trap dominant. So I spend a lot of time working on lat activation just to help with scap traction, and it just the lat being your biggest internal rotator.
Mm-hmm. Yeah, I don't have a specific test for it, but that's going to be reflected in the shoulder flexion and typically lack of internal rotation.
Adrian, typically I catch that, like Josh said, with shoulder flexion, but the other one that you can kind of look at too, if you can go on either side of the static posture debate. But if something is sitting in a position that creates one side of the pulley to be short and one side of the pulley to be long, it's going to have a harder time working towards that side that's short, or vice versa. And anybody who's got downslope shoulders or depressed shoulder blades, for that matter, is going to be somebody that you'd focus on with that.
Hey, Josh, Mark Dominic, UNCW. I was wondering if you could go back and talk a little bit about how you're integrating some of these correctives based on your movement screen. Are you trying to work with the strength coach and superset certain exercises into their workout program? I know you mentioned briefly that some of what they need will be addressed in the training room versus the weight room, but from an exercise standpoint, just what's the kind of logistics of how you're addressing these things you're identifying?
So affirm it depends. I go back to a lot of what Josh Porter said about the breathing exercises. Pretty much every one of my student athletes will get some form of breathing exercises, and it depends on the pattern that they fit. So we do try and integrate the breathing into the lift component. And then beyond that, it depends on what we find. So if it's they lack a little bit of internal rotation, a little bit of flexion, maybe have 75 degrees of hamstring flexibility instead of 90 to 100. I go talk to my strength coach and go, they need to work on deep anterior core. So dead bugs, planks, prone breathing exercises, things like that we can do as part of the lift. Now, if it's some kind of a glaring deficit, like 30-degree total arc deficit, 20 or 30-degree flexion deficit, some, put it in a PRI term, like really bad left AIC pattern at the hips, something like that, they'll be in a specific rehab program with me. And so we try and integrate as much as we can in the lift, but it's kind of I guess if you had to tier people on green, yellow, red, like the yellows are going to go work with the strength coach, the reds are going to be working with me. I guess, does that kind of answer your question?
Yeah, it gives me a little bit better idea what you're doing here. Appreciate it.
Going on the breathing techniques, we used to utilize a whole bunch of RPR in our warm up and part of our lifts last year. Would you feel like that RPR, that breathing technique, is more so for personal, as in like one-on-one type deal, or group sessions? Because for us, it was not well received with our guys with RPR. That was implemented by our strength coach. But I mean, it just made us feel and look kind of, oh, we're just rubbing ourselves.
So both myself and our strength coach are RPR level 2. So we actually started integrating that with our guys back in January. And at first it was, okay, we're rubbing ourselves. But the more they did it, they realized that, and also, like I was saying before, pre and post results, right? We were in the process of doing a sleep study, but for some reason they included vertical jump. And what our guys noticed was if they did the RPR pre and post, so they do a vert jump, do the zone 1 RPR, they jumped higher. And all of a sudden we had buy-in. So we got to where we were doing that as part of the warm-up. Like we do a 20-yard jog, RPR breathing, high knees back, RPR, psoas. Do the next exercise, RPR glutes. So we got buy-in, but only because they saw results. And so we started using it in January, had 2 months of that, and then now we're all on a conference call. So we were using it. The way I phrased RPR, like after I took level 1, was talking to some of our strength staff. I don't know that there's a better tool. If I'm a strength coach, if there's a better tool for me to influence breathing patterns and firing patterns prior to somebody lifting. Now, I think us as athletic trainers, we may have some better tools at our disposal, whether that's PRI, dry needling, all the soft tissue work we can do, massage therapies, the things that strength coaches can't do. But I think from their setting, it's one of the best tools available.
Anybody else with anything to share?
Hi guys, Allison here. I jumped on a little late. I was in another meeting. Going through your screening, do you test strength, upper body strength, like internal, external? Look for screens there in terms of muscle ratios?
So I don't personally, and the reason I don't is I don't know that I trust the 5 out of 5 manual muscle tests to give me a ratio. I've been trying for 5 years to get a handheld force plate, and I can't ever get my boss to buy one because they're so expensive. Now, even going back to 2010, I went on an interview with the Cleveland Indians, and for their major league roster, they do that bi-weekly, like with a handheld force dyno. And so I know at the major league level, that's really common. And if I had a handheld force plate, I would absolutely test ratios. I just want something a little more concrete than, oh, that's a 4 out of 5 today, or that's a 5 out of 5. So I would love to do that.
Gotcha. Some of my coaches have brought up to me, I think, is it Crossover Symmetry now they're adding that to their product where they have a handheld force plate, and they're saying that, athletic trainers, PTs, their manual muscle testing can be off by like 20%. And so it's something I kind of wanted to ask about, see if anybody else is doing it maybe too, to kind of, have a better stance, one in screenings, but two in when you're actually evaluating an injury, having concrete numbers to look at.
I have not seen that, but I'm going to look for it.
I know Terry Phillips, the PT at Driveline, utilizes a hand dynamometer, not a hand grip dynamometer, for a lot of his assessments. I will say, I think along those same lines, there's some value to be added when you're comparing active range of motion to passive range of motion and the capacity of those particular joints, muscles, what have you.
Crossover symmetry was supposed to come out and show us the hand force plate stuff about a week after this whole thing shut down. So hopefully when we get back in, they'll be bringing that in. So I'll let everybody know what it looks like.
Well, if nobody else has anything left to add, we can chat on something else, or we can end the call and try and pick this back up next week with some new topics. All right. Well, thanks for coming out, ladies and gents. For those that are in the CBATS group, I'm going to go ahead and send out another poll to see good times and dates to try and maybe do this again next week if people are interested.
Hey, so I had Adrian text me asking about getting a copy of the presentation. I'll post that, and I'll also post the actual form if anybody wants that.